Okay, now let's talk about interpreting OAEs and what results look like. There are actually many different pieces of equipment that measure and record OAEs. And so you have to I will show you as many different types of results as I can. But you have to be clear on what it is that you're looking for in order to be able to interpret the results correctly. Remember that OAEs are dependent on the integrity and the health of the outer hair cells. But the reality of the situation is this: the outer hair cells are really only responsible for the perception of less intense stimuli. So outer hair cells really, in the grand scheme of things, are only perceiving, they're only responsible for the perception of sound between about, 0, -10 to 35 or 40 dBHL. So, for the most part, OAE interpretation should take place in conjunction with the audiogram. When you have a hearing loss of greater than 35 dB, so a hearing loss that's in the more severe end of mild or above, you are unlikely to see OAEs present. If the hearing is normal and better than 20 dB across the board, you have a 99% chance of OAEs being present. 25 to 35 dBHL is what we call the zone of uncertainty, where OAEs may or may not be present, they may or may not be abnormal or robust. There are some things that you have to keep in mind that are going to affect OAE results, in addition to middle ear status, outer ear status. The noise floor is one of them. So if there's a lot of background noise in the room, the main result that we're looking at is the difference, the signal-to-noise ratio, the difference between the otoacoustic emission and the noise floor. So anything that makes the noise floor louder, like extra background noise in the room, is going to be problematic. Patient noise. In kids, in very young people and babies, this can be like physiological noise if they're moving around. Very young infants are very twitchy, and that can cause this sort of intrinsic physiological noise. The other thing that I'm actually starting to see a lot of right now that causes intrinsic patient noise is loud breathing. So people that have, a deviated septum, or, whatever kind of, people that are mouth breathers. Anybody that has sort of a very loud, audible breathing pattern, it may be difficult to get otoacoustic emissions because the intrinsic patient noise is very high. If the probe doesn't fit right, you're going to get poor OAEs. There are some things like gender and age that have been shown to affect the overall amplitude of OAEs, and those are certainly not things that would affect sort of present versus absent or normal versus abnormal interpretation, but it's something to keep in mind. And then your test protocol is really important. We're going to talk about interpretation in terms of present versus absent, but also normal versus abnormal. If you're going to use norms, or if your equipment is automatically using norms, you need to use the test protocol that those norms were obtained with, because otherwise you can't interpret the results. So if you have norms for a diagnostic, 500 to 8,000 hertz protocol on your machine, you have to use the diagnostic 500 hertz to 8,000 hertz protocol to use those norms. You can't use a screening protocol that is quicker and simpler, but still interpret with the norms from the other one. That's not how norms work. It's not clinically valid to do that. Ideally, you would have norms for your specific device and a specific protocol that you're using. Generally, for DPOAEs and TEOAEs, you're looking for signal to noise ratio, or the difference in amplitude between the emission itself and the noise floor. And you're typically looking for a signal to noise ratio of 3 dB or better at 1,000 hertz and lower, and 6 dB or better any place above 1,000 hertz. Those can lead you to classify OAEs as present. Not normal, but present. Normal versus abnormal is a different assessment, and it requires norms that have been normed on that instrument and that specific protocol. Sometimes you'll hear people talk about otoacoustic emissions as robust. And that's when, as an example, if you have an OAE that's at signals, that has a measured SNR of 20 or 25, 6 dB is present, 20 or 25 is robust. That is a very healthy OAE. Interpretation of OAEs can be done overall by frequency range and in conjunction with the audiogram. And ideally it should be all three. So you may be able to look at the OAEs and say, OAEs were present at all frequencies measured. And that's a great simple interpretation. You may be able to look and say, OAEs were not present at any frequency. But if they are present at some and absent at some, then that's how they need to be reported. Or, in some cases you can say, OAEs were consistent with the audiogram, and then provide the OAE printout. By themselves, OAEs by themselves are not synonymous with normal hearing. So you can't just test Timson OAEs and say somebody has normal hearing. It's not enough. There is a condition, a disease, a pathology, whatever you want to call it, called auditory neuropathy, or you might hear it referred to as ANSD, where an individual can have present, even robust OAEs, pure tone thresholds really almost anywhere, but they have this dysfunction of the auditory nerve that leads to sound being very distorted by the time that it reaches the central auditory nervous system. And these people struggle a lot. And it can range. It's a spectrum disorder, so it can range anywhere from almost a complete ability to understand and interpret speech to more difficulty than normal hearing and listening, especially in background noise. So OAEs by themselves are not enough to indicate normal hearing. And actually OAEs used to be one of the tests used for universal newborn infant hearing screening, and for a while it was approved to be used alone. So essentially if they passed the OAE screening, they passed their newborn infant hearing screening, and now it's at a point where OAEs are not supposed to be used as the only newborn infant hearing screening measure. It's supposed to be the OAEs used in conjunction with an ABR. So let's look at some samples here. This is an example of an OAE printout that you might see, and there's a couple things I want to point out here. You've got the left ear results on the left side and the right ear on the right side. This is essentially the chart in the middle, the line graph, is what is typically called something like a DP gram. And it's charting the frequency that you measured along the bottom. Along the y-axis, it's charting in dBSPL the intensity of the otoacoustic emission itself. And then what you see in sort of the cross-hatched area is the noise floor. So, if you look at the left ear for this one, again, you're just looking at the line graph, you can see from frequencies 3,000 to 8,000 hertz, the emission itself, where the asterisk is well above the noise floor. You don't even really see the noise floor in the high frequencies. Those are present otoacoustic emissions. One might even say robust in the high frequencies. In the low frequencies, at 2,000 hertz and below, the otoacoustic emissions are in the noise floor. And because they're not above it, you would say that they are absent. For the right ear, at all frequencies, the otoacoustic emission itself is much higher than the noise floor. And actually, if you look, the difference between these two ears is there's a big difference in noise floor between the two. So it may be that, if it's the child got cranky or started to move or started to wake up. At the bottom, you see a different representation. And you see this sort of bar chart. And the bar chart is showing you the lighter gray bars are the noise floor, and the black bars are the actual amplitude of the otoacoustic emission. So it's showing you the same information as the line chart. It's just depicting it in a different way for you. And likewise, the numbers, the table of numbers there, is also giving you the same information in a more exact way. So, really what you want to be looking at anytime you're looking at the OAEs, the graphs give you an easy sort of pictorial view, but the signal-to-noise ratio numbers are really what you're going to be looking for. So you're going to be looking for something that says SNR or dP minus noise floor, something along those lines. And if you look, you can see for the left ear, for the lowest three frequencies, the signal-to-noise ratios are very low. So those would be absent through 2000 hertz, but above, at 2.8 and above, you're well above the 6 dB minimum sort of requirement for present OAEs. If you look at the right ear, all the signal-to-noise ratios are well above 6. So they would all be present in the right ear. This is an alternative type of printout where you've got, and I know it's a little blurry, I apologize. You've got the same, I'm guessing it's the same person. You've got TE-OAEs on the left and DP-OAEs on the right. And so what you have, again, is this chart where you see the otoacoustic emissions themselves and then the noise floor in front. And again, you're looking for the SNR values. And you can see, and this was done as sort of a screening. So when you look at the SNR values, you can see where it's 6 and above, they get check marks for essentially passed. Same thing over here, where it's 6 and above, they get check marks for passed. In the DP side, you have the same column. It's portrayed differently, but above you still have this line chart where you see the DP and then the noise floor underneath it, and then a table displaying the actual physical SNR values at each frequency. This is a way to look at it with norms. So you're always going to see the noise floor. But in this one you have a shaded area, that light blue shaded area right there is showing you the normal range. And so you're looking at a couple of things here. First, you're looking at the difference between the noise floor and the amplitude of the otoacoustic emission, where again, from 1 to 3000 hertz, you have very clearly present OAEs. From 4 to 8000 hertz, you'd probably need to look at the actual numbers because that would be difficult to eyeball and see if the signal-to-noise ratio is where it needs to be. You can also see quite clearly that from 1000 to 3000 hertz, the OAEs are within the normal range. They're present and they're within the normal range. At 4000 hertz, it looks like it might be present, but not in the normal range. And again, it's certainly not in the normal range. Whether or not it's present would depend on the actual amplitude value. And then at 6 and 8000 hertz, the DPOAE is absent, and anytime it's absent, it's obviously abnormal. And here you've got two more. So again, what you're looking at is the otoacoustic emission as the two lines at the very top are the actual tones themselves. So you're going to ignore those and you're going to look at the line with like the little, almost look like little bugs, little star bugs. and then the bottom line with the triangles, which is the noise floor. And you can see there's a pretty good sized gap between the noise floor and the emission itself, which probably means the signal to noise that they are present, and the signal to noise ratio is going to be good. What you're looking for is this column right here that says dP minus NF, and that stands for distortion product minus the noise floor, and that is the actual equation that gives you the signal to noise ratio. The signal to noise ratio is good for all of those frequencies for this particular participant.